taking us through this session today. So far, we have had insight on many things, from the definition to the important pain management options and things like that. And now we are into individual symptom management. For that, we are going to deal with gastrointestinal symptoms today. For enlightening us on that, we have Dr. Arjun Pillai, who is junior resident at the Department of Palliative Medicine in M&J Institute of Oncology and Regional Cancer Center, Hyderabad. He has worked with Pallium India, and it's a pleasure to have someone who has been with Pallium to take us through the session. I hand over to you, Dr. Arjun, to take us through this session.
Thank you, Dr. Shall I share the slides actually?
Yes, you can go ahead. Yes, we can see. You can go ahead.
Shall I start the session then, actually?
Yes, please.
So,
go ahead.
Good evening.
Arjun.
Good evening to all. So, I'll just introduce myself. My name is Dr. Arjun. I'm actually working as a junior resident, doing a PhD in palliative medicine at MH Institute of Oncology and Regional Cancer Center, Hyderabad. So today we'll be discussing about nausea and vomiting in palliative care. Actually, unfortunately, I couldn't make my slides, so I'm taking the slides of Dr. Sridevi actually. So, why is it important for us to know about management of nausea and vomiting? So I believe all of us have at least once had nausea or vomiting in our life, and you know it causes severe distress to us. Actually. It affects our day-to-day activities, our functioning, as well as our quality of life. So nausea and vomiting is one of the most prevalent problems which cancer patients face actually. And it affects the patient's daily functioning, it hinders their quality of life, and sometimes it even causes non-compliance to treatment actually. Because most of the time they develop nausea or vomiting once they undergo chemotherapy or any other treatment actually, radiation.
Sometimes 1 minute, Dr. Arjun. There is some background noise we can hear. Is it just me or?
No, ma'am. There is a lot of background noises coming from.
So that's why. Sorry to interrupt. So that's why I thought better to.
Ma'am, there's a mosque nearby actually. So I believe it's a prayer noise from there.
You are using your headphones, right?
Yes, ma'am. I'm using a headphone actually.
Okay,
but
then.
I think the disturbance is too.
No, if you can just close any door or something.
It's closed, ma'am, actually.
Okay, then.
I'll try to speak much more. Yeah, ma'am.
Okay, then. Go ahead.
Am I audible now, actually?
Yes. We can hear you, but we had also that background noise also going on along with your speaking. So that's why I did interrupt. Go ahead. Let's see. Sorry about it.
No, sure. Like if the sound system is much more bigger, just inform me actually. I tried to change the place where I'm sitting. So, like I was mentioning, sometimes due to nausea and vomiting, it also causes non-compliance to treatment actually in patients. The reason being, most of them develop nausea, vomiting post their chemotherapy or sometimes even post radiation actually. So, due to the fear that they might again go through the same ordeal of having severe nausea, vomiting, they sometimes abandon your treatment and go home itself. Another is they feel like this nausea and vomiting is causing severe effect into your day-to-day activity, and it also leads to inadequate symptom control of other symptoms like pain or delirium as such. The reason being, those patients who are having nausea, vomiting, most of them they might be on oral medications actually. So due to severe nausea or vomiting, they won't be able to take their daily medications, and this in turn can cause severe pain for them. Other is it also causes severe distress to both the patient as well as family, because they feel like they're not being able to do anything to help the patient, and the patient himself or herself might feel like they're causing a huge burden to their relatives. So regarding the prevalence of nausea and vomiting, The stats say that in advanced cancer patients, nearly 6 to 68% of the patients develop nausea actually. And this goes to nearly 43 to 49% in AIDS. And patients who are having heart disease or renal disease, the incidence prevalence of nausea is from 17 to 48%, while in renal disease it's 30 to 43%. So you can consider an average of more than 40% of patients who we see have developed nausea actually. So the major objective of today's session is to learn how to stop. Our objective should be like when we are managing nausea is to stop or reduce the frequency of nausea. Sometimes it won't be possible for us to stop nausea or vomiting completely. So in such cases, we must also plan to reduce the frequency of nausea in such cases or vomiting, so that the quality of life of the patient isn't that compromised. The second objective for us would be to establish a compliance with treatment actually. So like I said earlier, sometimes just due to nausea vomiting, the patients must stop their treatment and go. So if you are able to manage these symptoms, that may help in improving the compliance with treatment. Sometimes it might also lead to a curative option in patients who are having curative cancer. The other is it helps us to administer oral medication. If a patient develops nausea vomiting, most of the time we change into a parenteral formulation. However, the issue with parenteral formulation is that though we can continue it for some time, it is causes certain unease for both the patient as well as healthcare providers like us. And moreover than that, whenever we are planning to discharge these patients, it becomes a huge difficult or challenge for us how to send these patients with parenteral medication. Even though it can be achieved, it itself poses a challenge which we can manage effectively if we're able to manage the nausea and vomiting. The last objective for us will be, of course, to improve the quality of life. So I'll talk about the definition of both nausea, vomiting, as well as retching. So nausea is defined as an unpleasant feeling of the need to vomit, often accompanied by pallor, cold, sweating, salivation, and tachycardia. So most any of us who had any nauseous stimulation or vomiting sensation, we know that whenever we vomit or have a nausea, it's usually accompanied by tachycardia and increased salivation action. Like we feel like there's increased secretions in our mouth. Most of the time we become pale or there's sweating also. This is nausea is just an unpleasant feeling of the need to vomit. Now vomiting itself is the forceful expulsion of gastric contents to the mouth. And retching is a rhythmic, labored, and spasmodic movement of the diaphragm and abdominal muscles which facilitates in vomiting action. So regarding the principles of management, like any symptom, the way we manage nausea and vomiting is almost the same. First, we try to correct the cause. Then we go with non-pharmacological measures, followed by dietary modifications, then finally by blocking the receptors of various signs, like the antiemetic or the pharmacological management. I'm audible, right?
Yes, sir.
Yes.
So first we'll
The
have a case
disturbance
study.
also is less. You go ahead now.
So first we'll just briefly put a case scenario actually. So a 56-year male with carcinoma of colon has persistent vomiting. So his history is that he received chemotherapy 3 days ago. He has come today for the daycare unit for his third cycle of chemotherapy. We will be discussing about the care management of this. I'm just putting a different case scenario. Then he also has a history of severe headache and weakness of right half of the body, and he reports dizziness, vertigo, and head movement, which in turn causes vomiting. And there is also increased pain over the right upper abdomen, which is a continuous type of pain, has increased in deep inspiration and loss of appetite. And this patient also got a history of heart disease and is on aspirin of 325 milligrams per day with symptoms of epigastric pain. He also has a history of fever and diarrhea and stomach claudication and ulcer. We will be going about the management of this patient at the end of the presentation actually. So first we'll talk about the non-pharmacological measures. So the non-pharmacological measure usually consists of avoiding situations which induce nausea and vomiting. This can be anything like food, smell, or dressing as such. So not only patient, when we consider ourselves also, we usually don't prefer to eat food or consume any substances where there's any foul smell or where it's unhygienic. It's the same situation with our patients also. So most of the time, this is one thing which we miss in our hospitals. Like sometimes in a government hospital, especially, there will be a lot of patients who are nearby, and it will be very unhygienic and unclean. There will be multiple foul smell or wounds in patients nearby. All these situations can trigger nausea, vomiting sensation. So trying to avoid these situations will also help in reducing the causes of nausea. Thus, just a calm, reassuring environment and pressure, and also nursing in the upright position. Actually. Other factors are good oral hygiene. So patients who are having poor oral care, having oral thrush or candida, all these patients that can be nausea and vomiting actually. So once the oral hygiene is maintained in these patients, the complaints of nausea and vomiting is also subsided. Nausea, vomiting due to oral candidiasis or thrush is a very common problem which we encounter in our day-to-day practice. And once we manage this oral candidiasis thrush, complaint of nausea and vomiting is also subsided actually. Other is control of malodor. Like suppose a patient is having cholesterol, has a huge fungating tumor or wound or ulceration of it. Seeing that wound itself or having the smell from this wound itself can trigger nausea and vomiting. So effective dressing of such wounds or proper cholesterol care can also decrease the malodor in these such cases. It will in turn reduce the nausea and vomiting. The other thing which you also mentioned is certain dietary modifications actually. So most of the time, what our patients usually have is that they usually have three. They are also always compiled to have meals just like our day-to-day life, like every 3 times a day actually. So instead of asking them to eat every 3 times a day, it is always better for managing dietary like for nausea and vomiting have frequent small meals. What we usually ask them is to have small proportions of food every 2 to 3 hours. Like instead of giving him 3 times of meal, we space it out on 2 hours, 3 hours as such. Other is to avoid fatty or sweet or spicy foods or carbonated drinks also. And sometimes bland foods and clear foods are much better tolerated rather than flavorful spicy foods actually for patients. So these two comprises of the non-pharmacological measures as well as the dietary modifications. Before I go with the pharmacological measures, I would just like to know what are the uh, medications which you are usually prescribed for nausea and vomiting management. Actually, you can just put it in the chat box. The commonly used antiemetic that you use in your practice, actually. Domperidone, Emicept, yeah. Only these two, like Domperidone and Emicept. So when we go, I will start with the pharmacological measures actually. So before going with pharmacological measures, like the two options which came in the chat box one was domperidone, other was ondansetron, I believe. So does ondansetron and domperidone work in the same way actually, or both of them have got different mechanisms of action actually? So does all these agents work in the same way, or they work differently? So all the agents which has been mentioned actually, all these work in a different way actually. So the way we go over the management of nausea and vomiting is that it is not like we have, if we mention prescribe one antiemetic, it is going to help in the each patients. We have to always evaluate the cause of vomiting, and based on that, the medication which we prescribe differs actually. In certain cases, a domperidone might work, while in certain cases, metoclopramide will work much effectively. And sometimes it might be a steroid which works more efficiently, or in sometimes ondansetron. Always we have to look for the cause of vomiting, and based on the cause, the agent of choice differs. So before going starting pharmacology measures, I'll briefly talk about the physiology of nausea and vomiting, the centers involved, and as well as the receptors and neurotransmitters involved. So whenever we go about the physiology of vomiting, there are 5 centers. One is the vomiting center, another is the area postrema, or is the chemoreceptor zone. Then there's a gastrointestinal system itself, which itself can precipitate nausea and vomiting. Then there's a vestibular nucleus as well as the cerebral cortex. Each of the centers can precipitate, cause vomiting or nausea in patients. So our management should be finding out which is the causative, which area is triggering nausea, vomiting, and based on that, our management plan differs. So regarding vomiting center, the vomiting center is located in the lateral reticular formation of the medulla, and it is the final common pathway actually. The vomiting center is a diffuse interconnecting neural network that integrates the emetogenic stimuli as well as the parasympathetic and motor efferent activity to produce the vomiting reflex. Next is the area postremia, which is also known as the chemoreceptor trigger zone, also known as CTZ. So it's a circumventricular structure located at the caudal end of the forefinger. And it's positioned outside the blood-brain barrier. Since it is positioned outside the blood-brain barrier, it is easily accessible to the emetic substances which are present in our blood as well as the CSF. Next, like I mentioned, in the GIT, we consider the stomach as well as the proximal bowel actually. So there can be local mediators from the endochromaffin cell, which in turn can stimulate the vagal as well as the splagling efferent fibers within the bowel. These can in turn signal the brainstem either directly triggering the vomiting center through the different nucleus like the nucleus tractus solitarius, or indirectly by triggering the area postremia, which in turn can initiate the emetic reflex action. The other two centers are the cerebral cortex as well as the vestibular nucleus. So the cerebral cortex has a higher input and it is usually triggered when there is any memory, fear, or motivation. And in case of vestibular nucleus, instead input from the vestibular nucleus usually also affects the balance as well as movement. So I have mentioned about the various centers of vomiting actually. So each center has got its own receptors actually, and each receptor has got its own neurotransmitter. So based on the receptor which is present in the each center and the neurotransmitter, the medication changes actually. So the common receptors and neurotransmitters present which are involved in nausea or vomiting are dopamine, serotonin, tachycanin and neurokinin, as well as histamine, acetylcholine, endorphin, GABA, and cannabinoids. So dopamine receptors, if you're aware of, they're divided into 5 subgroups, D1 to D5 actually. And the D2 subgroup is present in area postrema, while D3 is present in a central zone, which is associated with the generation of emesis actually. The D2 receptors are also found in GI action. When we go to serotonin actually, the main groups are 5HT1, 2, 3, and 4 receptors, of which the 5HT receptor is seen at the vagal afferent fibers in the gut, area postremia, and as well as the nucleus tractus solitarius, while the 5HT4 receptor is seen in the gastrointestinal tract. Trikinase neurokinin, we have substance P, neurokinin A, B, which binds to receptors neurokinin 1, 2, and 3, respectively. And the neurokinin 1 receptor are widely distributed in the CNS, including area postremia, nucleus tractus solitarius, as well as the GI. So one thing which if you go through all the receptors and neurotransmitters is that multiple receptor and neurotransmitters present in more than one area. So in the GIT itself, there are dopaminergic receptors as well as neurokinin receptors. Similarly, 5HT4 receptors also present in GIT. So it's not that just dopaminergic receptor just present in area postrema. All these different centers of vomiting, which I mentioned earlier, has got multiple receptors and neurotransmitters actually. So whenever we prescribe one of the anti-emetic agent based on the neurotransmitting area, it has got multiple, it acts on multiple regions of the vomiting. So this is a small schematic diagram of the entire thing which I mentioned actually. So this is the emesis pathway. As you can see, there's a gut wall, area postremia, cerebral cortex, and vestibular nucleus. So all the stimulus from these areas are sent to the vomiting centers, which in turn causes vomiting. And as you can see, the receptors are also mentioned here. NK1 receptor, 5HT3 receptor in case of gut wall. In area postremia, there is a 5HT3, D2, and alpha-2 receptors. And in cerebellar cortex, there is the NK1 receptor, GABA, 5HT. And in vestibular colon, there's acetylcholine H1 receptors. So things which can trigger vomiting, like some of the causative, for example, if you take case of morphine or digoxin, morphine actually triggers the dopaminergic receptors in the area postrema, which in turn cause vomiting. In case of raised intracranial pressure, it triggers the cerebellar cortex, which then mediates its action through the NK1 GABA 5HT3 receptor and results in vomiting. So the way we manage vomiting induced due to morphine will be entirely different with how we approach morphine, we approach nausea and vomiting due to raised ACP. Similarly, if vomiting is associated with any movement or vertigo, like if it's due to vestibular, our management plan changes entirely. It's not like if you are prescribing one anti-emetic, it should work in all the situations. Like I mentioned, whenever we are assessing nausea and vomiting, we have to always try to find out the causative agent. What is the cause for nausea and vomiting, and which of the respective vomiting centers are being triggered. Based on that, the medication which we prescribe also changes. So this is the classification of antiemetics based on the center of action. So the central nervous system, the vomiting centers, the agents which work on the vomiting centers are antimuscarinic, example hyoscine, In case antihistaminic also works in the vomiting center. For example, cyclizine, while 5-HT2 receptor antagonist like olanzapine and levofloxacin also acts in the vomiting center, while NK1 receptor antagonist aprepitant also acts in the vomiting center. When you come to area postremia or the chemoreceptor trigger zone, there are the D2 receptor antagonists like haloperidol, metoclopramide, domperidone, while the 5-HT3 receptor antagonists are granisetron, ondansetron, while NK1 receptor antagonists are aprepitant. In case of cerebellar cortex, the agents which work are benzodiazepine like lorazepam, cannabinoid like nabilon, and corticosteroids like dexamethasone. There's also the NK1 receptor antagonist like aprepitant. And when you take into consideration the GI system, there are prokinetic agents like 5-HT4 receptor agonist, again metoclopramide, then D2 receptor antagonists like metoclopramide and domperidone. Motilin receptor agonists are erythromycin, actually, it's an antibiotic. And sometimes anti-secretory agents also help in management nausea vomiting, like antimuscarinic agent like hyoscine, while somatostatin, analogs like octreotide and lanreotide also. Then there is a vagal 5-HT3 receptor blockade, like 5-HT3 receptor antagonists like granisetron and ondansetron. And again, NK1 receptor antagonist, aprepitant. Sometimes anti-inflammatories like corticosteroid like dexamethasone also plays an important role in management of nausea and vomiting. Sorry, just a minute actually. 1 minute. I'm sorry. Can I resume actually?
Yes, we can
Hello?
hear you and see you.
Is the voice okay actually?
It is, sir.
Yes, yes, go ahead.
So based on the area which I have, we classify like these are the certain classification of anti-emetic agents actually. The other way how we can go approach with the various anti-emetics are based on a cause. Like if it's a metastatic cause, one of the reason for nausea vomiting can be cerebral, like raised ICT, which in turn can trigger the chemoreceptor trigger zone, or can be MH to the liver, in which case there will be a toxin buildup. Actually. In such cases, the drug of choice which you use to manage will be steroids and mannitol in case of raised ICT. Actually. Suppose there's a meningeal irritation like an eleptomeningeal disease, again there will be a raised ICT, which can in turn trigger the CTZ as well as the cerebral receptors. And again, the drug of choice will be a steroid actually. Sometimes the medication itself can cause nausea and vomiting. For example, opioids. Opioids can stimulate the chemoreceptor triggers on the vestibular system as well as the GI system. In such cases, the medications of choice will be metoclopramide and haloperidol. The receptors which it acts on will be the D2 receptor, and in case of metoclopramide, it also acts on the 5-HT4 receptor. And in case of chemotherapy-induced nausea and vomiting, again, the receptors involved are the CTZ and GI. In such cases, the preferred agent will be ondansetron as well as dexamethasone. Sometimes NSAIDs can also precipitate in vomiting. Again, omeprazole and ondansetron will be drugs of choice. If there's movement related associated with nausea and vomiting, vestibular stimulation will be the usual cause. And sometimes we also see patients who are started on morphine who come to us with complaints of giddiness and vomiting. In such situation, promethazine will be a much better choice for management of nausea and vomiting. And if there's any mediation factor like fear, anxiety, which triggers nausea and vomiting, in such situations, an anxiolytic like lorazepam can help in managing nausea and vomiting. And if the cause is mechanical, like if it's constipation or a tumor structure of peritoneal deposits, we have to manage the constipation as well as manage the bowel obstruction for the management of nausea and vomiting. And in metabolic causes like hypercalcemia, hyponatremia, and liver failure, management of the electrolyte imbalance as well as steroids and ondansetron play helps in managing the nausea and vomiting. And in motility dysfunctions due to paralytic ileus or opioids, which can cause paralytic, which inhibits the peristaltic movement. In such situations, metoclopramide and bisacodyl will play an important role in management of nausea and vomiting. And mucosal causes NSAID, APD, or GRD can cause nausea, vomiting. Such cases, antacids or cytoprotective spray important. And microbes, like I said, Candida itself causes nausea, vomiting. Management of candidiasis through topical antifungals or gargles can help us in managing the nausea, vomiting. If it's herpes or any systemic sepsis, antibiotics or antiviral agents itself will play an important role in managing nausea and vomiting. So we have discussed about the various vomiting centers, the receptors involved, and the neurotransmitters involved. Now we will briefly talk about each, some of the commonly used agents, as well as how to approach a patient with nausea and vomiting. So as a rule of thumb, whenever we approach a patient, not only with nausea and vomiting, any symptom actually, first we have to assess with a proper history and clinical examination regarding the cause, whether there's any cause, what can be the cause of vomiting, and then we go with the correcting the correctable cause, as well as managing the consequences or complications, and provide a targeted therapy, like choosing an appropriate antiemetic agent. Like I mentioned, based on a proper assessment, we will be able to localize on which of the vomiting centers are being triggered actually, and which is the neurotransmitter involved. Based on it, our prescription will change actually. For example, if the patient is developed vomiting following chemotherapy, ondansetron will be a much better choice of drug actually for management of nausea or vomiting. Similarly, if it's due to raised ACP, it will be dexamethasone, steroids as such. If it is morphine induced, it will be metoclopramide. And we have to always choose the appropriate route for administration of these drugs, and also to find attention to certain delay. In this case, appropriate route in the sense if a patient is having severe nausea and vomiting, just prescribing them tablets won't help the patient actually, because due to severe nausea and vomiting, they won't be able to take these tablets, and in turn, it will not help in management of the symptoms actually. In such situations, if we prefer parenteral route, like a sub-Q or an IV route, will be much better. So in history taking, just like an assessment of pain in nausea and vomiting, we always assess the quality of nausea, vomiting, retching, and regurgitation. It is always important from our side to differentiate regurgitation as vomiting. Because most of the time the patients will come to us with complaints of vomiting actually, like sometimes it might be regurgitation. So always ask them how, like, the time interval between food intake and vomiting actually. If it happens just as soon as they take food intake, it will be most cases it will be regurgitation. So with proper history, we have to differentiate whether it's vomiting or regurgitation, and also ask for the duration. I think which we have to assess is whether this nausea or vomiting is persistent or intermittent in nature, and the intensity of it. Also, we have to ask for any associated symptoms like associated pain or any alteration in bowel habit, like constipation and severe abdominal pain might most commonly point to a diagnosis of bowel obstruction actually, even if latex is not passed. However, if the vomiting is associated with severe headache, giddiness, or episodes of seizures or loss of consciousness, it might cause so much more of an intracranial cause of vomiting. Other thing which we do is we have to also ask for the nature of vomitus action, whether the vomiting is bilious in nature or fecal content action. This again gives us certain clues or hints against the causative nature for nausea and vomiting. We have to also ask whether there is any things which that help them from relief from vomiting action. This can be any antiemetic agent or sometimes a change in posture itself. So the patient may say whenever they lie down, they have severe nausea, vomiting. However, on sitting up, the sensation of nausea and vomiting is subsided actually. And we also ask for any temporal factors and any drug history actually. Drug history like opioids, antibiotics, or any anti-cancer treatment also gives us certain clues regarding what might be the cause of nausea and vomiting. And in physical examination, we have to check for the abdomen for any mass, bowel obstruction, or bowel sounds, and any organomegaly as such. It's also suitable to do a rectal examination to just rule out constipation action. We have to also rule out signs of sepsis and there is any metabolic abnormalities like liver failure, renal failure, hypercalcemia, neurological signs. Regarding investigation, which we usually suggest in case of nausea and vomiting, one is the radiological imaging, like abdominal X-ray, CT scan, or MRI scan of the abdomen to rule out any local causes due to any obstruction or any mass in the abdomen. Actually, sometimes lab tests also play certain role in giving us clues regarding the causative nature of nausea and vomiting. Like it can be anything similar as a CBP, which might rule out sepsis, as well as a RFT for renal failure, as well as electrolyte levels for hypercalcemia, hypernatremia, potassium levels as such. Now, regarding the different agents which we are going to do, first will be metoclopramide actually. So, metoclopramide is one of the most commonly used drugs in a palliative setting, especially for management of nausea and vomiting. I believe in the chat box the most commonly mentioned was ondansetron actually. So earlier, even I used to prescribe online cetron. However, once I started working in palliative, I found metoclopramide is like based on cost we change the agent. In palliative setting, due to the prescription of morphine, most of the time we also prescribe metoclopramide actually, whenever they have any nausea vomiting associated due to opioids. So metoclopramide plays an important role in management dysmotility, dyspepsia, as well as delayed gastric emptying and chronic nausea. It has got two actions. One, it combines the D2 antagonism as well as 5-HT4 agonism. For 5-HT3 antagonistic action, we have to give a dose of higher than 100 milligram over 24 hours action. Another important role that metoclopramide plays is that it is a prokinetic agent. So the way prokinetic comes in play is that it triggers the cholinergic system in the gut wall and it stimulates it for a peristaltic-like movement. So it helps in management, or it has got an additional effect in management of constipation actually. What opioids do is the opioids actually impede this prokinetic effect. So whenever we prescribe metoclopramide, this prokinetic effect both comes into play. And the D2 antagonism also blocks the dopaminic brake on the gastric pain induced by the stress, anxiety, and nausea from any cause. And while 5-HT4 agonism has got a direct excitatory effect, which in theory can give them an advantage of D2 antagonist, particularly for patients with gastric sizing, functional intestinal obstruction. So regarding the pharmacokinetics of metoclopramide, its bioavailability is 50 to 80% per orally, and its onset of action, if you give it in parallel from like IM form, it's within 10 to 15 minutes actually. However, if you're giving an oral formulation like a tablet form, it takes nearly 15 to 60 minutes to start acting, and the time to peak plasma concentration is 1 to 2.5 hours after oral consumption. The plasma half-life lasts for nearly 2.5 to 5 hours, and duration of action is 1 to 2 hours actually. So there are certain adverse effects with metoclopramide. One is like acute dystonic reactions with the patient's skeletal muscle spasm, ocular crisis, which occurs in less than 5% of patients, more common in young girls and women. Other side effects include neuroleptic malignant syndrome, drowsiness, restlessness, depression, and diarrhea. So in certain literature, actually, metoclopramide is said to be contraindicated in seizure patients actually because it in turn lowers the seizure threshold. However, certain literature also says it can be used in such situations. However, you have to use it with certain cost caution. However, they haven't mentioned any dose limitation actually. So the situations in which you have to take certain care and focus on metoclopramide are epilepsy, Parkinsonism, pheochromocytoma, and when there is GI hemorrhage and perforation less than 3 days after gastrointestinal surgery. Like this is due to the prokinetic effect of metoclopramide, and other is in whenever we are suspecting a complete bowel obstruction or bowel obstruction with the presence of colon infection. I believe you have got a presentation of bowel obstruction on Monday actually. In that I will cover in detail about role of metoclopramide in bowel obstruction actually. So whenever we are suspecting complete bowel obstruction, we never prescribe metoclopramide. However, when you are suspecting a partial bowel obstruction, we can prescribe metoclopramide actually, because that is one of the management protocols in partial bowel obstruction. And metoclopramide also has got certain interactions actually. One is combination of IV metoclopramide and ondansetron occasionally causes cardiac arrhythmia. And as 5-HT3 receptor represents various aspects of cardiac function, including inotropy, chronotropy, as well as the coronary. And one thing is that we should never combine metoclopramide with an antimuscarinic like buscopan actually. So sometimes what we usually say in our practice is that patient might be having spasmodic abdominal pain, and in such patients they might already be on metoclopramide action for nausea vomiting, and they might be also be prescribed buscopan. We commonly say this in bowel obstruction actually. So this should not be done in practice because both the medications counteract their action. Like in say like the prokinetic of action of metoclopramide is counteracted by the antimuscarinic effect of buscopan action. So giving both the medication will be actually futile actually. It won't help in any sense. The next agent which we'll be talking about is domperidone actually. So similar to metoclopramide, domperidone is also a D2 antagonist, and it does not normally cause a blood-brain barrier. Another thing about domperidone is that it has got a dual anti-emetic effect. In the sense that it acts on the dopaminergic receptor on the chemoreceptor to invoke tryptophan in the area postrema, as well as on the D2 receptors on the GI system. This in turn counteracts the gastric dopamine brake. The plasma half-life of domperidone is actually increased by up to 50% in renal failure, so that needs to be taken in consideration whenever we are prescribing domperidone in patients who are having renal issues. Domperidone also causes less frequent, less severe undesirable effects rather than metoclopramide. like less drowsiness and less of loss of mental acuity action. And regarding its interaction, domperidone is metabolized as site system of enzymes actually. So concurrent use when it's type 3A4 inhibitors like ketoconazole, erythromycin, ritonavir, SSRIs, or macrolide antibiotic grapefruit juice that improves the domperidone plasma concentration, which in turn can increase the risk of QT prolongation actually, thus leading to osteoarthritis response. Now, regarding its pharmacokinetics, the bioavailability of domperidone is 12 to 18% per hour fasting. After food intake, it increases to 24%, and its onset of action is within 30 minutes, and the duration of action is nearly 12 to 24 hours. And the time for peak plasma concentration is 0.5 to 2 hours per hour week, and the plasma half-life is 7 to 16 hours, increasing up to 21 hours in severe renal impairment. And caution is needed whenever we prescribe domperidone in patients who are having GI hemorrhage, perforation, or within 3 days of gastrointestinal surgery, as well as in like similar to metoclopramide, complete bowel obstruction or bowel obstruction with the presence of colic. And certain adverse effects of domperidone are cause gynecomastia, galactorrhea, and amenorrhea, secondary increased prolactin secretion as well as reduced libido. Sometimes colic can also happen, and rarely pruritus, rash, and headache. Now, domperidone and metoclopramide are commonly used antiemetics. There are certain antipsychotics as well, which we use in our palliative care practice for management of nausea and vomiting. One of them is haloperidol actually. So haloperidol, as you all of you are, is a typical antipsychotic, and it has got a pure D2 receptor blocking action. So the antiemetic, by blocking the D2 receptor actually, it helps in managing vomiting and nausea. And it is usually considered as a second line drug in our management of nausea and vomiting, and it works very effectively actually. So most of the time, whenever a patient who is having severe nausea and vomiting, which is not, if the dopaminergic receptor is involved, and if it's not being able to manage with metoclopramide or domperidone, we usually prefer haloperidol actually. And regarding the dosage of haloperidol for management of nausea and vomiting, the antiemetic dose which we prefer is 1.5 to 5 milligrams twice a day or 3 times a day by mouth, or it can also be up to 0.5 to 2 milligram IV 8th hourly, which is usually normally lower than the usual antipsychotic doses. So haloperidol is most commonly preferred drug in the palliative by the palliative care team actually. Sometimes we also prescribe olanzapine. Olanzapine is also an atypical antipsychotic which has got a high affinity for multiple dopaminergic receptors like D1, D2, D4, as well as serotonergic 5H2A, 2C, 3, and alpha and adrenergic H1 and cholinergic receptors, all the M1 to M5 receptors. You can see olanzapine works on multiple receptors actually, and its antiemetic dose is just 5 to 10 milligram per day by mouth. Usually, we see medical oncologists or oncology to prescribe olanzapine whenever the patient is having undergoing chemotherapy, which high chemotherapeutic agent with high nausea vomiting potential actually. So they usually prescribe emisect like ondansetron, steroid, and olanzapine as well. The next agent is levomethomazine, which is a D2 receptor antagonist and is also utilized as a second line, third line therapy for refractory nausea and vomiting palliative care action. And the usual antiemetic dose which we prescribe is 6.25 to 25 milligram twice a day, or 25 to 50 milligram per day via subcutaneous infusion. Certain other agents are corticosteroids, like I mentioned. Corticosteroids can be used in nausea and vomiting due to chemotherapy or in management of malignant bowel obstruction, raised ICP, and it has also got a second line treatment of chronic nausea and advanced cancer action. Regarding its precise mechanism, however, it's still clearly unknown. So one of the possible theories which came as I can deplete the GABA stores in the medulla, in turn reduces the blood-brain barrier permeability to emetic roxas and inhibits enkephalin release in the brainstem. Now the dosage, antiemetic dosage of dexamethasone is 4 to 8 milligram per day for chronic nausea and can be increased up to 16 milligram per day for malignant bowel obstruction or raised ICP. Other agent is octreotide, which is a somatostatin analog, which in turn decreases peptide Y, neurotensin, and PIP, as well as substance P, and decreases the splanchnic blood flow. Regarding the dosage of octreotide is that it is nearly 100 to 200 micrograms 8th hourly, and is usually used for management of refractory vomiting as well as malignant bowel obstruction. Hyoscine is another agent which is used. It's an antimuscarinic agent. The way it works is it decreases the GI secretion and relaxes smooth muscles. Dosage is 60 to 120 milligram over 24 hours in case of malignant bowel obstruction. Other two agents are benzodiazepine, which has got a cerebral action and also an anxiolytic and anesthetizing Example is lorazepam. Other is cannabinoids. And dronabinol is one of the cannabinoids which is used and it acts via the CB1 receptor. So these are the multiple agents which you use for management of nausea and vomiting actually. And another thing which you have to consider is the cost actually. Some of these agents are much more expensive than the other agents. Usually in our practice, we don't take into account the financial point of view also. That is also one thing which you have to consider actually. The reason being metoclopramide is comparatively cheaper compared to domperidone. And like octreotide is an agent that is highly expensive actually. So we usually don't prescribe it in first time itself. We usually go with steroids and as such. We'll go back to the case study actually. So if you're able to recall, case study was of a 56-year-old male with carcinoma colon who was having persistent vomiting actually. So we'll put multiple scenarios in this. So the same situation, there's 56-year-old male with CA colon who had persistent vomiting. He came to us with complaints of colicky abdominal pain, distension of abdomen, and bilious vomiting.
Excuse me, Arjun, 1 minute. They have just mentioned in the chat, if you could just go a little bit slow.
Okay, like, should I go back to one of the slides actually?
No, they have just mentioned that, I'll just read. They have mentioned just, it would be better if the speaker can be a little slow as sometimes the voice breaks or some disturbances there. So maybe just be slightly slow in your pace, I think. That should be okay.
So the first scenario is a 56-year-old male with CA colon who has persistent vomiting, and he reports with colicky pain abdomen and abdominal distension actually. Also, the nature of vomiting is bilious in nature, and history of constipation is of 1 week actually. What do you think is the cause of vomiting like in this patient actually? Can you just put it in the chat box? Okay. So intestinal obstruction is the popular, yeah. So this is a case of intestinal obstruction. So most of intestinal obstruction will be managing. We'll be discussing about it in detail in the next session actually. So it most of the time the patient feels okay most of the time, and nausea depends on the severity of obstruction. And sometimes they feel better after vomiting. And it takes about an hour after the meal to vomit. And there's also an epigastric discomfort or pain in gastric irritation. So this is a mechanism of which the obstruction triggers the stretch receptors, which in turn causes release of serotonin from the mucosal endochromatin cell action. So the way we manage this patient would be by giving him high dose of steroids. Like we can go up to 8 to 16 milligram of dexamethasone. Along with it, we also give metoclopramide, provided it's a partial intestinal obstruction actually. If there's a gastrostasis, actually, we go with metoclopramide or domperidone, 10 milligram TID of 6th hourly. And if there's any gastric irritation, we also go with omeprazole 20 milligram BD as well as sucralfate. And you have to also stop the offending drug in case of gastric irritation. And one thing which you have to note is that in a patient who we are suspecting intestinal obstruction, after initiating them on metoclopramide, we have to also always look whether they are developing any spasmodic pain actually. Because if they are developing any spasmodic pain following administration of metoclopramide, it points that the obstruction is total in nature. It's complete obstruction. In such situations, we have to stop metoclopramide in order to stop any perforation actually. So next scenario is same situation as 56-year-old male with CA colon and persistent vomiting. He gives a history that he took chemotherapy 3 days back and has came today for his 3rd cycle of chemotherapy and has developed persistent vomiting. So what can be the cause actually? Like the cause and which area is stimulated in this situation actually, the scenario. Just put it in the chat box actually. Chemotherapy induced vomiting. Yeah. So what will be your preferred agent in this situation? Which medication would be suggest for this patient actually, since it's chemotherapy? It's better if you can write the generic name rather than the trade name actually. Ondansetron, Dexam. Yeah. So in this patient, it's chemotherapy-induced nausea and vomiting, and the preferred offending agent might be the chemotherapy drug actually. There can also be a role of anxiety in this patient actually, because sometimes patients develop nausea vomiting after first cycle of chemo. Following that, they might not develop nausea vomiting actually. However, that memory of developing or that anxiety or fear of developing nausea or vomiting can cause further episodes. So if it's chemotherapy induced, the agent we prefer is ondansetron or granisetron actually. The dosage is 8 milligram, 4 to 8 milligram twice a day, or if it's granisetron, 1 milligram BD. So usually we see that patients who are undergoing chemotherapy, the chemotherapy agent is given for 3 days actually after chemotherapy itself, so that it's continued. If anxiety is the cause of vomiting in such situation, lorazepam is a preferred agent. So lorazepam we go at 0.5 to up to 2 mg OD or BD dosing actually. Next scenario, again, the 56-year male with CA colon persistent vomiting. He presented to us with a history of severe headache and weakness of the right half of the body. So what might be the cause in this situation actually? Most recently, ICP, okay, intracranial pressure, raised. Yeah. So raised intracranial tension might be the cause of vomiting in this situation actually. This might be cause of any metastasis as such. So how will you manage raised intracranial pressure in this situation? Dexamethasone. So dexamethasone is one of the agents. So increased ICP might be the most common cause of nausea and vomiting in this situation actually. So we usually manage it with dexamethasone. We also go with mannitol actually, so that the raised ICP can come down. Mannitol is only given in the acute phase actually. After initial 2 to 3 days, we have to stop mannitol in such situations to manage the raised ICP, because there's a phenomenon known as rebound raised ICP actually. So we give mannitol and dexamethasone in the initial 2 to 3 days, after which if the cause of nausea and vomiting is the raised ICP, once we manage it with mannitol as well as dexamethasone, it comes down. So next it is again the 56-year male, persistent vomiting. This time he reports it associated with dizziness and vertigo, and head movement is causing vomiting actually. 3% NaCl isn't preferred for management of raised ICP actually. 3% NaCl we only use for management of hypernatremia. In the earlier situation, it was just due to raised ICP. Mannitol and dexamethasone is good. So yeah, so this scenario, patient he's also complaining of vertigo and dizziness actually. What can be the cause and what would be the preferred agent actually? Just try to recall the antihistaminic anticholinergic. What is the cause actually? Yeah, vestibular. So vestibular system is the cause here, because classically the patient presents a history of associated dizziness or vertigo actually. This is also sometimes triggered due to a CNS lesion as well as opioids actually. Our agents are antihistaminic and muscarinic. And certain agents like opioids, digoxin can also cause. The way we manage this is by giving haloperidol 1.5 milligram to 2.5 milligram OD or BD, as well as metoclopramide can also be given 10 milligram TID. And trial of another opioid can also be considered. Like the opioid itself is a causative agent for nausea and vomiting actually. So for a summarize, like if all the initial agents which I mentioned doesn't work in management of nausea and vomiting, or if it's refractory nausea and vomiting, we also consider continuous infusion actually of either metoclopramide or haloperidol for management of nausea. And even if after that the symptom of nausea and vomiting still persisting and causing severe distress to the patient actually, we can also think in terms of palliative sedation actually for such patients. That's just for the completion sake I mentioned. We don't usually consider, and it's usually rare to go over palliative sedation patients with severe nausea and vomiting, but that is an option which we also have actually. So just to summarize, what we have to always identify the likely cause of nausea and vomiting actually. And by identifying the cause of nausea and vomiting, we can identify the pathway, which is the vomiting center involved, which is the neurotransmitter involved, and which is the receptor involved in this. And based on that, we can choose the most potent antagonist to the receptor identified actually. And based on that, we can predict its antiemetic efficacy. Always choose a route of administration that ensure that the drug reaches the site of action. The reason why I mentioned this multiple times is that most of them which we commonly see is that patient might come with nausea and vomiting, and they might be prescribed an antiemetic tablet actually, which they won't be able to tolerate. And always titrate the dose carefully and review the patient frequently. And you have to give the antiemetic regularly. If the symptoms persist actually, also reevaluate what can be the additional causes. Whether any other treatment should be required for an overlooked cause, any alternate treatment can be also suggested for different causes apparent actually. And if you are combining antiemetics, always take into consideration the potential drug interaction that happens. Sometimes an antihistamine can counteract an effect for prophylactic agent. Let's stop sharing actually. Stopping the slides actually. So this was regarding the management of nausea and vomiting. I hope you have got a bit idea of it. If there's any doubt, can you please put it in the chat box? We'll try to address.
Thank you, Dr. Arjun. Quite informative, and they were also participating actively. So that is something which is very helpful. There's a question in the chat about palliative sedation.
Okay. So palliative sedation as such is a thing which we only consider if the symptom which is very refractory in nature is causing severe distress to the patient or caregiver actually. So what we do here is that the usual line of medication, the first line and second line of medications are not working, and further multiple causes of the distressing symptom is being evaluated. Even after that, we are not able to manage the symptom effectively. In such a situation, we go for considering palliative sedation. So way we go with is that we usually prefer a sub-Q route actually. We combine certain medical agents. Most of the time, if it again depends on what is the cause why we are sedating the patient. Suppose it's pain actually, we go with the combination of an opioid, most commonly morphine, as well as a benzodiazepine like midazolam for such patient, and we sedate them. Suppose the cause is nausea or vomiting, we go with metoclopramide or midazolam or sometimes haloperidol. The thing is, palliative sedation, it's a bit tricky and difficult to just address in just a question actually. It itself has got a detailed session actually. And it's not one of the it's a thing which we don't prefer to use initially. We keep it as a last resort actually. Like whenever we are considering palliative sedation, it's done after multiple discussion with the entire team and after taking input from the entire team, not only doctors as well as nurses, social workers, and the input from the caregivers as such. Because once we go with sedation, actually, the patient will be sleeping most of the time, actually. And sometimes the patient or caregivers might not agree with this, actually. So I think that somehow
Exactly.
Yeah.
Because they have been asking this question, and I have been telling them it will be dealt with in end of life care, because this came up even when opioid session was going on. Yes. So yes, it will be dealt with in end of life care. And as Dr. Arjun mentioned, you have to put many things into perspective. That is not one of the management option to have palliative sedation in your armamentarium for these symptoms. It is when a collective decision, the condition of the patient, the response of the patient to various management options, and then comes multidisciplinary team discussions within the medical teams, discussions with the medical team and the family, caregivers, patient. everything. So it's not a simple answer to be given. So palliative sedation is like a final option. And when that palliative sedation decision has been made collectively, that's why it will be dealt with in end of life care, where like there are, for that also, no, like you have for diagnosis, you have so many criteria, that's why you make the diagnosis. Like that, for this also, there are many things to be considered to say that the patient is in the stage of palliative sedation. He is ready for that. Only then that will happen. And as he mentioned, in that, the method is subcutaneous is used because you're not going to do something very highly interventional for the patient. So, and then he was very smart in telling the drugs used will vary depending on what stage the patient is and what is the patient's symptom needs addressing. I hope that is clear. So, and then it will be covered in end of life care session also.
Any other doubts regarding nausea and vomiting actually?
So that's also, I was about to check in the chat box. There's nothing there now. Like if anyone has any more queries, please go ahead. Because few things what I thought of highlighting was you should know what is the cause for the nausea vomiting and then deal with it appropriately. Not one drug, one size fits all will never work in this, because the mechanism or how it's happening varies. So you have to tackle accordingly. So commonly what all you will be facing or seeing different types of patients with same nausea vomiting in different presentation is what was explained in detail. That is something to be kept in mind, and the various drugs which are available have to be used appropriately and you will get the good benefit. Route of administration is very important, and non-pharmacological sometimes. And then especially when you're prescribing morphine, if you don't prescribe an antiemetic, your prescription is not complete. Prescribing an antiemetic, prescribing a laxative, these two are part and parcel of that prescription. So it's an incomplete or even, sorry to say, you're negligent if you don't prescribe these two. So those are things which are to be kept in mind, because just because of that nausea vomiting, many times patients don't take morphine. So if you just give the antiemetic and just for 2-3 days, after that it will not be required. So that is one symptom which will be covered by the antiemetic, and they will not have nausea vomiting. Like once they are into 5-6 weeks of the treatment, they won't need it at all. And then they can use it as and when required. So those are type of things which are very important to be kept in mind. Any questions, or shall we go on to the case and come back? Sini, I think there are no more questions at present in the chat box. So maybe we can go ahead with the case presentation and then come back and discuss both.
Can you hear me?
Yes.
Yes.
Good evening, all. So I'll be doing the case presentation today. Can you go to the next slide? It's a 70-year-old female who is diagnosed with carcinoma stomach, stage 4 carcinoma stomach. Her main complaints are, next slide please, nausea and vomiting since 2 months on and off, and abdominal pain since 2 months. Going to the history of presenting illness, actually patient had on and off nausea, vomiting, abdominal pain since last 2 to 3 years, which was treated symptomatically by local doctors as gastritis, and she was to take treatment on and off. Now complaining of severe nausea and vomiting, unable to take oral food since last 2 months, along with the abdominal pain and altered bowel habits. She doesn't give a history of completely as of diarrhea or a constipation. She says it's altered, and feeling of tiredness and disturbed sleep since 2 months. On examination, patient appears pale, cachectic, pulse is 88 beats per minute, blood pressure is 108/60. sorry for the typing error, millimeters of mercury. Cardiovascular system, S1 is her. Respiratory system is normal, this one for her. The gastrointestinal system, as patient had abdominal pain, I was unable to do the detailed examination, but palpable mass was kind of felt in epigastric and left hypochondriac region. Next slide, please. This all investigations and the treatment was started just 10 to 15 days before the case was taken, because that's when she went for the detailed investigation. So she was sent to a lot of investigation like USG, abdomen, hemoglobin, hematological parameters, CT scan, GI scopy, histopathology, all of which led to the final diagnosis of carcinoma, stomach stage 4, for which she was treated with tablet capecitabine and endoscit and morphine, endoscit for the vomiting and morphine for the abdominal pain, and capecitabine for as a chemotherapeutic agent. The next slide. Coming to the psychosocial aspect, she was a 70-year-old lady with 85-year-old husband who is also a known COPD, and with the 7 children, 3 males and 4 females. 6 of them were married and have a children, but youngest son is yet to be married. Children want her to be operated and get cured, but the present condition of her, the treating doctors have advised better not to go for any surgical procedure. And one more, the important thing, patient does not know the diagnosis. So the main concern of the next slide, please. The main concern of the family members is whether to disclose the diagnosis to the patient. Can we go to the next slide? These are the medication, that is capecitabine, endoscit, and morphine. Next slide, please. Her main concern is now nausea and vomiting and abdominal pain. And to go for any, parenteral medication, she's not willing to stay in the hospital, so she wants to be at home only. So that's the reason they've gone with the prescription of the oral medication. Next. So 70-year-old lady with the stage 4 adenocarcinoma stomach complaining of nausea, vomiting, and abdominal pain on palliative chemotherapy with antibiotics and analgesics. So whether patient needs to be informed about the diagnosis, the main thing, children are feeling guilty that they neglected the complaint for the initial 2 to 3 years. Whether the husband needs to be informed because he is also not maintaining it a good health. And as I already said, the children wants her to be operated, but treating doctors have advised not to go for any physical procedure because of her condition. So need for counseling and explaining the condition to the patient becomes important here. So that's all. One more thing I would like to highlight is, yes, as the session is mainly on the nausea and vomiting, the detailed history of the vomiting was not, maybe I know I could have inquired a little more, which was lacking here. But her complaint mainly is she takes the feed within half an hour to 1 hour, she tries to vomit, it goes off. So whether it is a regurgitation or a vomiting, or is it the tumor is causing intestinal obstruction. And one more thing, as to discuss in the case, if this is a case, we should go for the other line of management. I don't know, that will be the point of discussion here. Thank you.
Thank you, doctor. The thing is that, like, after the session, that you would have had an idea that what and how, as you mentioned, to go and find out what. And with her, the mass itself could be causing stasis, obstruction, everything could be there. So that is the thing. And then
pain score was
someone has asked what was the pain score.
7 to 8.
Okay. So maybe, Senior, can we come out of this presentation so that we will have everyone?
Yes, ma'am.
Thank you, dear. See, few things, like, as you have mentioned, like the points what you have mentioned there, like, have to be dealt with. You've had communication sessions before, isn't it? So now you know what is that, how would you go forward with this? Like, see, you answer the question, does the patient needs to know?
I think yes, patient needs to know, because she's been suffering from a lot of time. She's been asking actually the kids, what is happening? Why am I having this?
So if I'm not wrong in asking, see in your Dr. Viju Raghavan session, how clearly he said, they will ask, oh, they have been telling this, what is that? So the patient indirectly knows what it is, but people are hiding from her. So it will take time. So what is the protocol you will use to convey the news to her?
Right.
So that's all. It is just not going to happen in one session. So you may have to explain, you may have to have discussions with the, there is collision also there, isn't it? The children don't want to tell her, but the mother wants to know. So finding the right balance. So this is a case of everything, all in one case you've got there.
Yes.
So see, that is how. So as we always say, when you start seeing patients, all the 20 sessions you will have in hand. So nothing wrong. So that's why you're getting trained to manage everything. 20 sessions, you can manage 2000 or 2000 odd patients. So, okay. So those were the things. So initially, whether the patient needs to know, husband needs to know, all that. And then managing her symptom as such, you have to see, are you still seeing the patient or is she totally at home?
No,
or what
ma'am.
is happening?
No, she's at home. The relatives are going on and off for consultation and taking the medication going. She's not willing to go because she's been a little, tired of running around the complaint. She is not willing to even get admitted and get treated. So the kids are going and forcefully taking her to show and take the medicines and go.
No, does she come to your, like they come to your hospital to get the morphine? Only for that they come, right?
Yeah.
So other than that, like any facility of home visit or anything like that, is there in your place?
No. They are coming from far place. Nobody is doing any home visits. They are only coming on a regular interval and taking the medications and going patient party.
So and then is her nausea, vomiting still very intense, or how is it at present?
Nausea and vomiting is relatively reduced. A pain is actually is there. Initially, she was started actually on NSAIDs, then she was shifted to morphine.
Yes, you said she's stage 4. So ideally, better to be on morphine to have at least some form of pain relief and better quality of life. So the main concern were like conveying it to her, conveying it to the husband. The third and fourth points, what were there? Just recap.
Those two things, and whether the
And I think it was whether the children wanted to
children wanted her to be operated.
Yeah. You
and
go ahead,
guilt, actually.
Dr. Arjun. You go ahead with anything, what you want to add on.
No. Like the 2 points, one was whether children's guilt, actually, like they didn't take her for treatment during initial stages of the past 2 years. They were thinking about gastritis, and other was regarding active treatment action.
Yes.
So, like ma'am mentioned, regarding first thing is it seems like stage 4, and her age is also 70 years. And based on the history what ma'am said, she prefers to be at her home itself, is what I can understand actually. So in such situations, it would be better first, like most of the time, this guilt of the family members might be because they might feel that they have ignored her, right? Some other cause which has been there in the past itself. That is one thing which we most commonly encounter in our practice actually. Like when they find out that there's a terminal illness or terminal, the patient's at terminal state, they would feel that they have to do something to save the patient actually. And this in turn, like they will be trying, that's from their own affection care for the patient actually, but what it in turn does is that it affects the life of the patient actually in turn. Like they will trying to save the patient, but the quality of life of the patient will be severely affected. In this situation, I would suggest that it was better to talk with the care. Like I don't know who is the primary caregiver. Like there are 7 children is what I can understand. So who are the primary caregivers? Who are the primary decision makers? Yeah. So having a discussion with them or planning a family meeting with them regarding what is the current condition what is the most probable pathway where the disease can take her into, like how much based on the stage, like I believe there's a liver deposit also. So she appears to be in a terminal phase. So giving a proper counseling to the discussing with the regarding what is the situation. Hello, am I audible?
Yes, some breakage.
Okay. Like discussing, having a family meeting in order to address their concerns as well as giving them, because most of the time what we see is that most of them wants to go for active curative treatment actually. So we always go like it's patient's autonomy or a family's autonomy in our setting, but we don't give them an informed decision actually. We just tell them their treatment option is there and they go for the treatment, but giving them a proper informed decision, like what are the treatment options available, what are its pros and cons, like what will be the side effects, what are the benefits available with this treatment. Once you give them a proper explanation to them, they themselves might say that we don't need any active treatment, we would like her to be comfortable. Because once we talk to them regarding what are you expecting with the active treatment, they said they want their loved ones to be comfortable. Actually, that's the crux of it. Actually, so instead of focusing on that and having a proper family meeting would be a much better point, I would say. Regarding the guilt again, with the family meeting, we can elicit certain concerns which they had. Now, regarding the collusion part, like I would go with what ma'am said actually. Just one point which I like, it's a right for everyone to know what is their disease actually, but that doesn't mean that they need to know always. Sometimes the patient they won't be willing, like they might say that they want to know, but once we give a warning shot or something, they might say that no need, I need not know, I just want to be comfortable. So that are some things which you have to keep into a consideration. Other is I want to know whether steroid was tried in this patient. I saw emissit
No,
and
sir, it was
morphine.
not tried. That's what even after your class when I got steroid was not tried and it was given.
Back to you, ma'am.
Steroid does work, okay? Steroid, patient comfort. You can just give for few days. And even for vomiting also it works. Steroid works in many ways. And you give it for short term. You're not going to give it for long term. So the symptomatic relief is one thing. Steroid will help. And from a little bit more to add on to what Dr. Arjun was telling also was, see, they want everything to be done. You ask them, no major surgery, then they say, no, 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 we don't want that. What is that everything? No, is a very vague word. Because everything will mean something for them, something for us, and something for the medical fraternity, and everything is different. So ideally having a better discussion. See, one person, you said that son, you just talk to the son and then explain everything to him, and then he goes back to the family and explains, or sometimes that will work. Sometimes they themselves, even though it should not be that, they all siblings will be fighting among themselves. So then they may say, no, no, you explain. So something like that. It needs, we can't decide and say what it is. So explaining to them is more important, and telling them, and then asking her what she wants. And if she wants symptomatic relief, and then try those things and see, and if that keeps her better, like everything, pain relief, comfort, give her some mobility, and eating small frequent meals. See, normally everyone, like say, how I don't know how her husband is 85, so he may not be able to look after her. So they may be feeding her just once or twice in a day. That will not work for her. So even these simple things, no, see, generally everyone is used to eating twice a day. But as soon as someone is in this stage of the disease, small frequent meals every 2 hours, and then don't force them, because they are unable to eat. That's why they're not eating. And their appetite itself may be low because of the disease per se. So all these have to be explained to the family and to the patient, especially with this GI type of things. Explaining more to the family is also important. They think, oh, I'm loving and giving everything. She's not ignored. No, she's unable to eat. She doesn't have an appetite. So you give her the way she can tolerate and cope. So these are type of things which you have to explain both to the carers and to the patient. And then the patient will say, oh, this is what I've been telling, but they don't. So something like that will all come up when you see patients. So she'll say, oh, exactly, this is what I've been telling, but they have been telling me I have to eat more. I just can't eat. So those type of things that has to be explained, and trying steroids is something which has to be done. And then having like maybe 1 or 2 discussions you may need, and then explain to them, give them time to think, come back, and then explain and see what is best. Always what is best for the patient is what ultimately we are going to do. There are a couple of things in the chat. Let me see. Is she able to eat liquid diet at least? So
She's
that
able to
varies.
take.
Huh?
She's able to take liquids from liquid. She's
So
able
that's
to take solid. She's not able to take.
So exactly, you have to see what is best for the patient and then take it from there. That is what. So pain, from the pain point of view, she's on morphine 5 milligrams only now. So that you can titrate. When was she started recently or?
Pain she was started in the March only. Before that she used to take NSAID something.
See, in that case, no, if it was just started initial stage and all, every 2 weeks you have to review. So you have to review in 2 weeks and then get her to an ideal level with morphine. They normally they have better quality of life. See, because that helps them a lot. So review her in 2 weeks time. And then, are you the person seeing her, or is it another team?
No, ma'am, I am not it's other team who is taking care of.
So that's all. So some regular follow-up with her will make things better. She has to be seen for her pain management, psychological, and then conveying the information, all those things, no? All elements of it. What does she know whether it is stage 4? Do everyone know whether it is stage 4? What is stage 4? See, just as Dr. Raghavan said, no, what we understand, no, stage 4, USG, all that they will not know. So they may think 1, 2, 3, 4. That is not what it is. So
no, the son knows relatively she has terminal.
So that's all that explanation.
He is conveyed it to his siblings, but the patient and her husband doesn't know. Patient is asking what is happening, why is it happening. So they are a little in dilemma whether to.
No, it's just matter of time and explanation. It is not an easy thing. Few times it will take, and then in due course, no, the patient themselves pick it up. And one day when she comes, she will ask. They are not telling. So can you please tell me? Many times this happens. They are not telling it to me. So that time, as Dr. Raghavan said, you have to ask. You have to make sure that she is comfortable to know what she's going to hear from us. If she says yes, you go ahead and tell. No, she said, no, I would like to have someone with me, only then tell. Then do that accordingly. So see what is the best and where she is, what she wants. And from that only you move forward. Pain management, you've just started. I think if you follow it up, if that is followed up more, it will be taken care of. I was just checking in the chat box. Just because she's taking liquid, they've mentioned that it shouldn't be a complete obstruction. Anything else anybody wants to ask? You can even unmute and ask, or Dr. Arjun, you would like to add on anything? Please do.
No, ma'am.
In that case, I will pass it on to Sinia then.
Ma'am, if there are no more questions or comments, I think we can wind up the session. Thank you so much, ma'am. And thank you so much, Dr. Arjun, for being here with us today, expecting to have many more sessions with you. Thank you all for joining with us today for today's session. Thank you so much. We'll see you on the next session. Bye-bye.
Thank you, one and all.